Well, welcome everyone. Thank you so much for being on this teleconference with us this morning. I'm Dr. Kyle Peters. I'm a clinical pharmacist in Sioux City, Iowa, and Dr. Mark Loafman from Northwestern in Chicago will be on the teleconference with us today. We are the faculty co-chairs for the Patient Safety and Clinical Pharmacy Services Collaborative. This morning we're going to talk about delivering better, safer care in communities nationwide. And the PSPC is short for the Patient Safety and Clinical Pharmacy Services Collaborative. So if we get to the next slide here, we have two questions to run on. These are questions that are to be thought of during this presentation that we'll hopefully answer. So where is the PSPC and where are we taking it? So we'll give you some info of our progress and where we've been, and then how are our teams in action? And we'll discuss that a little later on. So with that, I will turn it over to Dr. Mark Loafman. Mark?
Thank you, Kyle. Dr. Mark Loafman, I'm at Northwestern School of Medicine, a family physician. I've been working in community health centers for about 20 years. I trained there in my residency and fellowship at Brown University in community health center settings, and been doing that in Chicago since. Working with HRSA for a number of years, both locally and nationally in terms of performance improvement. And our work has always been in the underserved communities, working on health disparities. That's really our goal. Move forward. So we're going to work on moving the slides forward here a little bit. I wanted to talk a little bit about the setup. Again, as Kyle talked about, we're going to go over where this PSPC, and again, I know we have a lot of alphabet soup. You have the acronyms in your program as well, so we're going to work with all that together here today. We're going to talk a little bit about questions to run on. So how reliable is our care? And Amy, if you could advance for us there. There we go. Get the slides moving forward. How reliable is our care? And this schematic talks a little bit about, from the left, sort of the autonomous system that we've grown up with and many of us still work with, moving across to the right, which gets to an increasingly more competent system and a system that brings more safety. So how reliable is our care? It's really a function of our system and our culture. That's really what determines it more than the individuals in it. And we know that sort of coming from this time when we've really had autonomy, where physicians have used their individual skill, their custom crafted processes, and many of us remember practicing healthcare where we had a blank progress note and a blank order set, and all was supposed to come from within. So we know the error rate, predicting error when you have a system that's custom crafted and individualized, that the predictability of that is really its chaos theory. You just don't know what's going to happen in that, and certainly we don't want a healthcare system that's dependent upon chaos theory. As we move to the right to teamwork, we know that systems tell us we can get the error rates down to about 1 in 100, 1 in 100 encounters, but that's several times a week, and sometimes in hospital settings several times a day we're still committing errors. So to get over to the level of a highly reliable organization where we have that 6 sigma 1 in a million error rate, it takes a lot more even than teamwork. So moving from autonomy to teamwork and then finally highly reliable organizations is clearly where we're all headed to healthcare, and we're in the process of doing that through the safety work we're doing. The PSPC Collaborative, the aim was to start looking at teamwork, because we know as we look out in our primary care systems and our community practices that we still have a lot of autonomy going on. So the PSPC started here looking at teamwork and trying to sort of get standardized processes in, working with high-risk patient populations, bringing in some protocols and starting to see improvement. And we've seen quite a bit of success at this level. Our goal now is to take that and move it, spreading it over to becoming more highly reliable. And I've given some examples there of the airline industry and anesthesia in medicine where we put our lives in the hands of a pilot or an anesthesiologist without really thinking about who that individual is. We're still, when we pick a doctor, we really do worry about who that individual physician is, because we know that's going to make a difference. But the airline industry and anesthesia, for example, has gotten to the point where we defer to the expertise. We know basically that all of them, no matter who it is, they're going to do the same thing, and we're going to get the same outcome. It's been hard for physicians to think about that it shouldn't really matter which one of us is writing the orders or which one of us is evaluating the patient, that the outcome should be the same. But that's really where we need to get to if we want to bring quality. So we've had more than a decade of calls for us to act. 99 report, 1999 to err is human. We've watched things come through asking us to do things differently. The status quo in primary care has really been physicians treating patients without collaborations, kind of the doc alone in the exam room with the prescription pad. We've accepted errors as okay or not our problem. And really we've tolerated a huge amount of non-adherence and poor outcomes, sort of saying the patient's non-compliant. You know, I document that I did my part, and that if the patient has a bad outcome, it's really on them. And that has not gotten us where we want to be. We've kind of accepted that's been a problem. So the call is for us to have significant change. If we want to get from that level of autonomy, as posted here, to the point where we're highly reliable in healthcare, we're not talking about tweaking or you know, fine-tuning the system. We're talking about significant change. And so the target for that, really, the bullseye on that status quo is, as we see it, is the chronic disease care for our patients in primary care. That's a huge opportunity for us to bring forward some safety improvements. So coming back then to the PSPC aim, what's our aim, what's our target? It's to save and enhance thousands of lives a year by achieving optimal health care outcomes. So we want to kind of get away of that idea of saying non-adherence and poor outcomes are just part of the environment we practice in, and kind of achieve the optimum outcomes. Also along the line is doing what we do safely, eliminating adverse events. There's quite a bit of disturbing evidence out there on how much harm we cause by the misuse or ill-advised use of medication. And to get those things done, we found the highest yield way seems to be to increase clinical pharmacy services. And I would add, it's not really a pharmacist program. Pharmacists happen to be experts at clinical pharmacy services, so we draw on them heavily in this program, but it's really about the system of care is what we're talking about here. Who drives this work? It's really the national planning team. So we have several federal core team members. They're HRSA, public health officers, the Office of Pharmacy Affairs, and many other HRSA-related agencies that work with us. And then there's faculty members, and folks like Kyle and I that have you know, real jobs in the community. We're out practicing. We see patients, and Kyle does this work as a pharmacist. I do it as a physician in the community, and we're co-chairing this project. We have many other players involved. We have a public-private alliance, people that are working together in the private industry and the public sector with our agencies, but large and growing leadership coordinating council of philanthropic organizations, nonprofit organizations, professional groups working with us, and then of course federal partners, other agencies, the FDA being sort of the prime example of an agency, and we're starting to work now with CMS as well. And most importantly, the many, many community partners and leaders who are out there you know, doing this work every day. So what does it look like? This is a simple picture of it. The patient enters you know, the medical home, which is really, we're very focused on the integrated patient care model, and as part of that, they will receive clinical pharmacy services, and those things together help us to optimize the outcomes and lower the adverse events. And we've kind of learned to talk about this not just as a primary care physician, but rather as comprehensive primary care, the integrated patient primary care environment. So it's, again, we realize just a physician alone, even if they have a pharmacist friend, is not going to get this done. It takes much more comprehensive systems work than that. In that process, we really looked, as I know you have, at the medical home model, and we know that phase one is sort of the doctor's office. And I think originally people thought having a medical home means I have a primary care doctor. That's certainly the start. It gets you basic, and what we know now is episodic care. I refer to that as the Marcus Welby model. Some people still remember who that is. But it really was, again, the doc alone. And even Marcus Welby at some point needed to bring James Brolin, the actor, in to have a partner. He wasn't able to do it by himself. He needed help. And so we really, that model gets us the same old outcomes, which we know are just not good enough. But as this medical home model has evolved, we've got systems and teams for better outcomes. We know we want to get to teamwork and then finally to highly reliable states. We really need to have this teamwork. So we move down the pyramid, building the doctor's office to expand the medical home. That gets us into preventive care, planned care, allowing us to do more system-based care. But if you really want to target the disparities, and certainly for us it's the underserved communities, but I think we know that the gap nationwide is for all patients in the healthcare system. There's a disparity between what we want and what we're currently getting. To get there, we need a comprehensive health home. Our community health centers, of which now there are thousands across the country, are providing that environment, so we're targeting that. That's our populations that we serve. And I put in there a couple of arrows showing clinical pharmacy services are being kind of the key components to help drive this expansion of the medical home toward a more comprehensive system. I'm looking at where we are on the roadmap for improvement, and so this was published in '08 in JAMA. Doherty and Conway talked a little bit about the 3 T's, and the T's indicate translation, and in terms of translational research, with 1 being basically the science. If T1 works, we know the science works. T2 is the treatment works, so the science leads to a treatment or an intervention. T2 says, yes, that works. And T3 is kind of where we've been stuck, that we don't know that the system works to deliver that treatment to the right person at the right time. So that's where we are. That's where we're working. We feel like there's been a backlog. I think people have talked about that lately. There's been a backlog. This slide sort of shows that all the little red dots coming into that is the basic biomedical research that tells us the science works. We have good ideas. T2 level, we have trials to tell us that the treatment works, that when we use that science in treatment modalities and interventions to change outcomes, that works. But when we finally get to the level of improving performance and getting better outcomes, there's just this bottleneck, a backlog. And many of us have seen that, and they know the work you're doing tries to get us there. That's where we are. That's where we're working. And if we do this right and do it well, we open up that funnel, implementing what we know works to get better outcomes. That's sort of performance improvement work. It's a different kind of research, but it's very important work, and the PSPC is grounded in that. We also talk about the medical home being the exam room that the patient's seen in, and we know for patients to get better that even if they have an excellent, safe room in that home, that if the rest of the home isn't safe, or if they leave the home and go out to the community of practice, they're going to other organizations, other agencies, other providers, going back and forth across institutions. We can think of that as a community of practice, and if those intersections aren't safe, if people are getting hit crossing the street or they don't have a bridge to get across the troubled waters, then it really doesn't help us that much if my room, my exam room in my house is safe for them. So this community of practice is really the idea. We've talked about in the safety net having an integrated regional safety net. And the systems actually are already there. We're not talking about a radical change. We're talking about organizing the systems that are already there. So we have our patients in our communities. We have our community health centers, again, which there are now thousands, safety net and community hospitals across the country, working together and bringing in partner organizations with schools of pharmacy, schools of medicine, nursing, etc., all working together into an environment which really is now being described as clinical integration, bringing clinical pharmacy services, performance improvement, health IT, all those things together into the communities of practice. So that's the idea, is to get the integrated safety net, and the idea with this is to get better outcomes and reduce disparities, to get this community of practice functioning well. And again, I know I'm preaching to the choir with this audience that you folks are engaged in this work with us, and we're excited to be here. Health status breakthroughs in the high-risk patients of population. So again, our program, PSPC, is really not a disease management process. That's sort of old thinking, but we do start with specific diseases to get our teams engaged. And when we looked at who our populations of focus are, who are our teams taking care of, this is the typical story. So the patients have at least, on average, this is an average situation, 8 medications per patient, an average of 5 chronic conditions, and an average of 3 providers caring for those conditions in some way or the other. And so, one of our calls last year, we had Dennis Quaid, who's had a personal bad outcome experience with adverse drug event and is nationally leader in working towards safety. He was on the call, and I was listening to him, and it made me think a little bit about the drama, all the drama here. If he was an actor in a movie about this, what would the soundtrack be like for patients who have these criteria moving through the healthcare system? And we know the soundtrack would be scary music. I mean, we'd be frightened for them, waiting for the next error to happen, the next bad outcome. So we really want to try to change that. We looked at 30% of the patients in all of our teams. 30% of the total patients really fit this criteria. So almost a third of the patients they're caring for have scary music playing as they move through the drama of the healthcare system trying to get better care. So again, we're not disease management, but we start with the disease indicator as a focus area. And so more than half, 54% of our teams chose diabetes. You can see what some of the other ones are there. They're easy things to go to work on. It's the low-hanging fruit, we like to say. And they pick patients who were out of control. So, you know, a lot of performance improvement starts by sort of looking at the whole system level. How do we do something different consistently for every patient? This project specifically is sort of like a special ops team for the out-of-control high-risk patients. And they go in, jump over that barrier, go down to the scariest patients, those that are really, really out of control, and grabs them and pulls them up and provides that safe environment, trying to change that soundtrack a little bit. So the idea, and this is sort of what drives our work, is really imagining a future. And this is sort of how we want to think. If there is a scary soundtrack, if we are feeling a sense of urgency for our patients, watching, and we talk about this, you know, watching if we don't manage this better, this patient's going to end up on dialysis, this one's going to have a stroke or heart attack, this person's going to have a bleeding complication from their coag meds. If we watch that happen, it's almost like seeing them standing in that intersection watching the bus come to hit them, and we want to do something about it. So there is a sense of urgency that we're feeling about trying to get better outcomes for our patients. And so we're imagining a future when all of our patients are in this proactive comprehensive medical home, which would be a great place to be, that they're receiving indicated planned preventive care in the right way. So the right patient's getting the right things at the right time. They understand what their meds are intended to do, so they are not just sort of following along blindly, but they're actively participating in care, and they're safely using those to get the goals that we know work. Again, this is that T3 work, doing what we already know works, getting it there. And they're really part of a world-class community of practice. So that integrated safety net we talked about is that they really each transition of care, wherever they go in the system, it's world-class. It's doing the best we can do. And finally, I think that's the environment that health professionals want to be in. We work collaboratively together with joy. I know many of my colleagues are burnt and toasted trying to react to all of the negative coming at them. And it's the same is true for, I think, our nurses. And I know with our pharmacists that are out there trying to fill scripts at incredibly high rates and work in the big box stores. I think there's an opportunity to bring joy back in terms of this kind of work. And we feel like that our PSP program is doing this, and really that status quo, that this is blowing the doors off of that, and it makes us very excited. You know, this is built on the IHI breakthrough model for improvement, so there's nothing really new about this approach. It's just doing what we know works. So using a series of rapid improvement cycles to significantly change the status quo drift to something much, much better. We've had success with our populations of focus, and I'll show you those data in just a little bit. And our goal now is to take that and really, with a roadmap, spread that to more patients, to more conditions, and to more communities. And we have a goal of 3,000 communities to be served with this program. What is that roadmap? It's a change package, and you're probably familiar with the role of a change package in the breakthrough model for improvement. But the change package really is it details the leading practices. So it tells us that T2 work. What is it out there that people know makes a difference? What are those goals for the improvement process? And it's developed by harvesting lessons from the field. What works? What are high-performing organizations do that are achieving outstanding results? And we've done this in PSPC. It's reviewed and vetted by a panel of experts. So we have our faculty together who have looked at this and put this package together. And then it serves as a catalog of leading practices that teams can use. They don't have to reinvent the wheel or discover their own. They're just adopting what we know works. This is how it looks schematically. There's 5 elements. The 3 in the middle in the pyramid are really the patient clinical care environment, that it's patient-centered, that it's safe med use, and it's about a team that's integrated. And the other 2 are really more systems issues, that there's leadership commitment across the board, and that we have measurable improvement as well. The breakthrough model meets the change package. So these are really 5 components we've culled from the breakthrough model, that there is a focus on outcomes, that it's evidence-based with guidelines, that it's allied health working together at the highest level possible, changing practices, being responsive to data, and that there's a culture that's changed that goes all the way to the top. So those are elements from the breakthrough model, and it fits our 5 elements with the change package. And the way we say it basically are patient-centered care, safe med use, integrated care, delivery, measurable improvement, and leadership commitment. And this is all written up, and our teams have this. And lastly, as we sort of try to get into the environment to make the change, we realize that it's a team sport by definition. So moving away from autonomy, getting providers to buy in, to work together, kind of have three core elements of that. First is to reframe a little bit. I think before you engage people to do things differently, you have to set the environment. So we really frame around the patient-centered care. Patients are customers, and many of our health systems look at the doctor as the customer. They want the doctor, the referring person, to be happy, and certainly that's going to be a business goal, but the patients are our customers. We want to involve physician champions early and often. They need to be part of this from day one. And I've highlighted and bolded this theme. It's not new work, and I think that's been something that we push and find resonates with people. Folks, in healthcare, we have too much to do already, and this is really not new work. It's a better way, a new way to do what we've already need to be doing and have not been able to get done. So we really want people to change what they're doing to new ways, not add another new list to do. And about allied health, bringing people in, standardizing what you can and handing it off does resonate with physicians. I think most of us are comfortable with that. That's typically how we function. It's doing that in a way that they feel safe and comfortable with is really how this works. Secondly, finding common purpose. And to get better outcomes with less hassle is something everybody's interested in. To do that, you make the right thing the easiest thing to do, not a harder extra thing. And again, this notion of bringing joy back. I think people in healthcare are willing to work hard. They're dedicated, want to work hard. They want to have some reward to that. And lastly, the third element is courage. And change and for safety does take courage. Clinical pharmacy services is a tool. We're not sort of, this isn't about promoting pharmacists or about promoting our community health centers. It's really about getting the outcomes we want. Transparency. And finally, we talk about that you don't really need permission to put patients first. So lots of times folks tell us, the doctor won't let me do this or that. We remind them that if you see an error about to happen, you have permission to act, and you don't really need prior approval to do that. So we want our folks to be engaged at that level. These are individual teams, and that's some of the numbers of patients they have that are out of control. So these are exact numbers. Some teams have started with 3 or 4 or 10. Others as many as 100 of their out-of-control patients. This is at baseline in September of 2009. By a year later, you can see the blue bar shows the number that have come under control. So this would be something like an A1C goal, a blood pressure target, a cholesterol goal, an INR in range. Those are all the kinds of things that are happening, but the common theme is that they're in control. This is another way to look at that. 54% within 12 months came from out of control. And again, these are not the easy to take care of patients. These are the folks that they deem were their high-risk, difficult patients. Teams are working to get safety here, so that we've seen adverse events fall, potential ones to 60%, 60% drop, and the actual ones 50% drop. We've also seen, we've projected what this will look like at scale up. So there are projected to be 40 million people in the community health center population in the next couple of years. We're well on our way to get there. At our 30% rate of high-risk patients, that would be 12 million patients who would need and benefit from CPS. Millions of potential adverse events could be avoided, with each one being, there's documentation that over $8,000 can be saved per adverse event. So the size of impact here is huge when we look nationally. Spreading PSPC, we've had 3 years now, so 1.0 is the first year all the way to our current year, 3.0. The organizations, we started with 200, got up to 350. Some of those were sort of scaled back and consolidated as we went into round 3. So we're still at over 300 organizations involved, 128 teams, over 90 health centers, 26 hospitals. And again, going from 2.0 to 3.0, we did some consolidation because the work got more complicated and more complex, so we consolidated a little bit. There's 57 schools of pharmacy, and I believe there's 100 around the country, so our goal is to get all schools of pharmacy involved. So I'm going to leave you and hand off to Kyle here in a second, but I wanted to say, why not make this the norm? Why not make this the way our patients get care? So imagine this future, and I want you to think a little bit now, maybe jot down some notes, be prepared to get in our chat room in a little bit about what are you hearing that fits your goals for both this effort that you're doing as a group and also your organization, and what aspects of this is already on your to-do list. What aspects of this is work that you want to do, because again, we're not going to get very far by adding new work. We need to redo the work that we're currently doing. So I'm going to pass off to Kyle and let him pick up here. And Kyle's a pharmacist that's doing this work in Iowa at a very high-functioning community health center. So Kyle?
All right, thank you, Mark. Mark covered a lot of great information, talked about kind of where we're at, where we're going. So really our goal today is also to inform the participants on the call of the potential that you may have of partnering up and getting this work to go forth. And we're going to spend the next few minutes talking about a few specific examples. So if we look at the aim again of the PSPC, it's really to save and enhance thousands of lives by achieving optimal health care, eliminating adverse drug events, and increasing clinical pharmacy services. And when we talk about increasing clinical pharmacy services, we kind of use a backdrop of the 10 clinical pharmacy service elements. And these include medication access services to patients, so maybe using more generics, using patient assistance programs, using $4 generic programs to make sure that patients can obtain their medications. We know that if they don't take their medications, it doesn't really do them a lot of good if we write the prescription. So we need to find a way they can get it. The next is patient counseling, where we explain to the patient why they're taking the medication, how to take it, what side effects may occur, and maybe how long they will be on it, that if it's a chronic medication, they need to take this for a very long time. The third one is preventive care programs, so maybe doing A1Cs, immunizations, BMI calculations, things like that to make sure the patients are aware of their health and we could prevent complications from occurring. Drug information services to patients, this is pretty important when we give them pamphlets or information or just answer questions they may have so they understand their therapy better. Medication reconciliation is very, very important, and a question that would probably come up would be, how would a community pharmacist in a rural setting be able to really help out the doctor's office? And medication reconciliation would be one of those ways. The pharmacist and doctor could review the patient's medication list, make sure that the patient is getting their medications, filling them regularly, that the doctor has everything dictated in the chart correctly as far as the right dose and directions. And by doing that, everyone's on the same page and they really know what the patient is taking. Provider education is something that I do quite often. I have 13 to 15 different providers that I consult with. So if they have diabetes questions, I'll educate them about the medications and recommendations I have. By doing that, we can really have a better comprehensive care team with that knowledge sharing. Number 7 is a retrospective drug utilization review, so reviewing a group of patients on certain medications, seeing if there's any potential problems. Medication therapy management is reviewing the patient's chart, their problems, their medications, and making those recommendations. Disease state management is something that pharmacists do quite well, especially chronic diseases such as anticoagulation, diabetes, hypertension, and asthma, where they're given collaborative practice agreements and authority to make adjustments and changes. And then the last one is prospective chart review and provider consultation, so reviewing a chart and making those recommendations. So with these 10 CPS elements as the background, we look at how we can integrate them, but it's important to note that these don't have to just be done by a pharmacist. They can be done by any member of the care team. And it really depends on the organization where these CPS elements may fit in. And even though all 10 of them are great and there's good work done because of them, it's not expected to do all 10 on every visit. And I think it's important to keep that in mind. One of the things we do in the PSPC is we have monthly calls with the teams. And this last call in January, we had an assignment where we had 4 high-performing teams, and we discussed patient interactions. And so the information that I'll talk about today was from one of our teams in New Mexico. And Dr. Krista Salazar did a very good job presenting the patient and the case. Their POF, or population of focus, that's the group of patients they're focusing on, is patients with diabetes mellitus with a hemoglobin A1C greater than 10. So as Mark mentioned earlier, these are the high-risk patients who may have adverse outcomes. unless we give them the proper care. And so the 4 questions that the teams had to answer was: 1, describe 1 clinical pharmacy services interaction with a patient. 2, what clinical pharmacy service elements were performed. 3, what potential adverse drug events were identified or prevented. And then how did this make you or your team feel about the work? So the patient that she talked about was a patient with diabetes who was brand new to the clinic. They have a clinic that is healthcare for the homeless, and so the patient came in. She hadn't had her insulin for 2 days, so not feeling well. She had a lot of increased thirst, urination, fatigue. None of the providers were available, and so the nurse went to the clinical pharmacist and said, "Can you see this patient?" And the clinical pharmacist said, "Sure, I can do that." They brought the patient back into a room and obtained a finger stick glucose, and it was 463. So very, very elevated, patient not doing well at all. And the pharmacist asked, what's been going on the last couple of days? And she says, well, I haven't been out. I haven't had my insulin for 2 days. I've been out because she fled her home with her daughter to escape domestic violence. So she got her daughter and left, didn't bring her meter, didn't bring her insulin with her, none of her other medications. And the patient was actually staying at a women's shelter at the time. And really, the patient's main goal was to provide the best life for her and her daughter. And so by getting her health under better control, she could accomplish this. And I think she came to the right place because they did a lot of great work for her at the health center. The clinical pharmacist talked to the patient, gave some education, looked at their old insulin dose, the insulin she was on, and calculated a new dose. They had samples available where they were able to give her free of charge, so she didn't have any money with her, but they were able to get her on some insulin, do an injection in the office, and then kind of monitored her for an hour to see what her blood sugars were, made sure the symptoms were getting better, made sure she was doing better. And the patient was encouraged to come back after she picked up her daughter from school. So if we look at the CPS elements that were performed during that visit, the first one was medication access services to patient. So the patient got some new insulin. She got a new glucose meter, test strips, and glucose tablets in case the patient had hypoglycemia. Without this assistance, she would probably have not really received the care she needed. She wouldn't have any supplies, and she couldn't care for her disease. The second thing that occurred was patient counseling. The pharmacist explained how the new insulin worked, explained how it was similar or different to the insulin that she was on, and what to expect as far as the onset, peak, and duration of action. The third thing that was done is medication reconciliation services. So obtaining that history of what have you been on in the past, what dose were you on in the past, what was your last hemoglobin A1C, it allowed the pharmacist to dose and develop a new insulin regimen, a regimen that would be safe and effective for the patient. And the final thing that was done was disease state management. So the pharmacist calculated the dose and had the patient administer it. So by doing these 4 things, the patient went from a blood sugar of 463, very thirsty, very tired, with frequent urination, to feeling better and having the potential to have a more normal life. Now, if we look at the safety aspect, and I think this is where the PSPC is very big, in the coordination of care, we're focusing more on safety than probably what has been done in the past. And so if we look at hyperglycemia and associated complications, so this was prevented. By getting insulin, the patient decreased the risk of having diabetic ketoacidosis. Polyuria, polyphagia, polydipsia, and fatigue were all decreased. Hypoglycemia was also prevented. So by taking the right amount of insulin, by getting the proper education, hypoglycemia was prevented, so the patient wouldn't have any issues with that. One of the important things that really stood out during this presentation was they said their old policy, if a patient came to the clinic and their blood sugar was elevated, they would call the ambulance and take them to the hospital. And so I specialize in diabetes, and quite often I see blood sugars in the 400 and 500s, and it's critical and emergent, but we wouldn't send those people to the hospital. We would give them a dose of insulin, see how they're doing, give them good education and follow-up. And because the clinical pharmacist was part of the patient-centered medical home care team, that was their new policy, where they would meet with the pharmacist, consult with the pharmacist. What this has done is it's decreased the amount of time, money, and energy that is spent on patients with hyperglycemia. So instead of going to the hospital, they're able to be treated there in their health center. They're able to save the system money and resources. And I think that's really important when we look at all the budgetary issues we have coming up, that if we can save the system money and resources and better take care of the patients, they're really better off. When we asked the question, how did this make you or your care team feel about the work, it was fascinating to hear that Chris explained that they really never thought about it. They never communicated it as a team until this question was asked. When it was asked, they had a great outpouring of responses. It made them feel efficient and effective. And so as Mark mentioned earlier, people get discouraged. It's the job, they get tired of it. But by doing this good work, the team was re-energized. They were excited that what they did actually mattered. And it really made them recognize that they have a positive impact on the patient's lives by improving the knowledge and treatment of diabetes. So this was one patient, but they impacted that patient's life. The other patients they see, they have the same goal of really making the lives better of the patients to provide safe and effective care. And by doing this, the team has really changed their idea of just punching the clock, seeing patients, and going home to be anxiously engaged in a good cause. They're looking for more situations and opportunities to make a big difference. And that's exciting. It's exciting that this work is really allowing people to get to that point. So questions to maybe think about and ponder that we'll hopefully answer at the end are, what excited you about the story you just heard? And then what potential do you see for the Patient Safety and Clinical Pharmacy Services Collaborative to have a bigger impact on patients' lives? With the PSPC, we are in the third year, and because there have been a lot of teams and a lot of interest to join us mid-part, we have open enrollment. So HRSA recognizes the value of open enrollment for organizations who maybe weren't ready to go in the beginning of PSPC 3, but they're ready to go now. And so if they want to join now, they have that opportunity. This has an opportunity where the teams can get familiar with the work, understand the work, and even partake in the work, and be ready to go for the fourth year. So what open enrollment really means is teams can join any time. They can join the collaborative cycle and participate with current PSPC teams. They can participate in the monthly phone calls, just like the one we discussed. There are learning events and other collaborative activities that we would have them join. They can really learn and benefit from the 120 teams that are already doing the work. There's a lot of good information sharing on the listserv that occurs where people have questions. They'll receive answers of how to do things better, different, to get to their goals. There are quarterly informational calls that will be offered, and the next one is actually March 10th of 2011. And so if any of you on the call are interested or would like to pass this information on to doctors' offices, hospitals, pharmacies, colleges of pharmacy or medicine that you deal with, the next call will be March 10th, and more information can be obtained from patientsafety@hrsa.gov. There is another great website with information. It's healthcarecommunities.org. And this is a great website that has a lot of the information and tools that's used in the Patient Safety and Clinical Pharmacy Services Collaborative. And so by going to there, you may be able to obtain further information. So our charge is really to get involved in this work. We know it's great work. We know we're doing great things, and we really want to spread the work. We need your help in coordinating the efforts to make this as comprehensive as it can be. It's the right thing to do for the patients we serve because it's safer. There's increased and better pharmacy services, improved health outcomes, and it's not new work. It's work that we're already doing, so we can improve upon our tasks and really do what's best for the patients. And we can do this to integrate services to maximize community health. So for more information, please visit hrsa.gov/patient safety. Or if you do have any questions, we probably don't have time to answer a lot of the logistics about open enrollment at this time, but please go to patientsafety@hrsa.gov to find information there. So for question and answer, a couple of questions that we would like to pose is, why not make this the norm? Imagine a future in your organization or program where what you are hearing fits your goals, and then which aspects of this work is what you want to do. What excites you about this work that you've heard, and what potentials do you see with that? And so with that, Mark and I will entertain some questions at this time. Mark, are you on the line with me?
Yeah, I'm here. I think Julie's going to help us a little bit, too, to field some questions from the chat room if they come in. Julie, are you back on?
I do not believe I'm back on.
Oh, we hear you.
We heard you,
Oh,
Julie.
great. Perfect.
Yeah, welcome back.
Well, unfortunately, I don't believe I can see the questions from the chat room, but I wanted to ask a question about both of you. First of all, thank you for this presentation. I think it's very exciting and very engaging work. As we think about some of the things that are going on in our healthcare delivery system, Kyle, you touched upon medication reconciliation. And we know that within meaningful use, there's some patient safety components related to maximizing your technology or using your technology meaningfully, related to e-prescribing and engaging with patients and offering them visit notes about what the dialogue had happened. Have you seen in any of your communities how they might be taking the work that they started perhaps in 1.0 and they're starting to align it with things like meaningful use and the opportunities for the incentives within that program?
Yeah, I mean, Kyle can probably talk about some specifics, but I think, you know, what I really like about what you're saying is it's a big theme here. There's so many things going on right now in healthcare that, you know, it's kind of like that whack-a-mole game at the arcade. Somebody pops up something and we go after it and try to whack that one down only to have another one come right up. So this idea that really all of these things are aligning toward a common theme. And I think the meaningful use goals, you know, I think you do see organizations going after them as sort of must-dos and got to get the dollars. But if really we reframe that and make that safety work and quality work toward the measurable goals we have, then it really becomes the same work. And I think that's exactly right. So many of the elements of meaningful use that are related to med management, safety, med reconciliation, and all that are accomplished by PSPC. And we are seeing teams that have made that connection and brought in their IT and their EHR folks to this effort as part of their core team. Kyle, do you have other information about it?
Yeah, I think, you know, you hit a lot of the high points. When we're looking at meaningful use, there are a lot of aspects that really require pharmacy's assistance. And so we've seen health centers reach out to other pharmacists in the community. So some health centers have in-house pharmacies, but a lot of them have contract pharmacies. I know our team in Sioux Falls has reached out to a pharmacy in the community and has had a great relationship. They've seen a lot of good patient care come from this. And a lot of times we talk about the message of don't just be in your silo. Don't only look at, well, this is my job as a pharmacist. I don't need to talk to the doctor or the nurse to figure out what the patient's really on. We recommend good dialogue between all the players. And this is nothing new to you as the patient-centered medical home. Really, you need a lot of players involved to have those discussions to make sure that the patient has the right information. One of the things that I believe we'll see more commonly as time goes is maybe better access to records. The pharmacist will have access to the chart notes, the labs, the medication list that's in the EMR. And by having that, they can review it and make sure that there's minimal drug interactions or problems.
You know, I see another question here on, is this available for clinics that are not FQHCs or CHCs? And the answer is yes. Here's the caveat: is it's a HRSA program, and so HRSA, you know, really is the federal agency that takes care of kind of the underserved patients. So it's some component, whether it's the hospital, the school of pharmacy, one of the team members, the population of focus really should be an underserved population that may be Medicaid, doesn't have to be uninsured, it's underserved in that sense, or a special population, HIV, homeless, migrant, a minority population, rural health setting, etc. So something that HRSA says, yes, this is who we take care of, that's all that's required to get the job done and to be part of the system.
Thank you so much for that. I know, Kyle, as you mentioned, just engaging with your community, we have a clinic, Marillac Clinic in Grand Junction, Colorado, who serves the uninsured, and they went out and spoke to the local Walgreens. So I think you should not assume that even larger organizations would not want to create a connection with you, and Marillac Clinic was quite successful in creating a link with the local Walgreens and making the connections with the pharmacists there, and having a way for that underserved population to have a connection with their medications. And what we've found in that is that through looking at some data with the local hospital system, they've seen in that patient population their ER visits go down. So by creating those connections, we bring value to the community. One of the things, we have a wide variety of folks on the call today. Can you talk a little bit about maybe just some small places to start for perhaps smaller primary care practices to work with their local pharmacists? Just any stories or suggestions that you'd have for the group as a place to start. Just begin.
Yeah, I mean, I think one of the chat room comments goes to that specifically. It says, I love the story of a very complex patient, describes how to meet the patient and family where they are, but that this can be overwhelming. So exactly to your point, what are the potential small steps to start the collaboration? I think it gets at that. So there are places where things align, and I think part of our challenge has been the kind of the big box retail stores with pharmacy, have a certain sort of goals about volume and getting patients through, and obviously selling some other things while the patient's there to get their prescriptions. But still at the heart, it's a drugstore, and the pharmacists, they're there. So e-prescribing tools and other things that put us together. And I think, on the retail side, what works for them is if a physician has a reason to, steer their patients to that pharmacy, it's going to be good for their business. And so sometimes it's a business alignment to say, how can we work together more tightly? How can we be more consistent? And ultimately, that's going to be better for the patient if the pharmacist and doctor are working together. So that may be a reason to get it done. The e-prescribing concepts of being able to get a list of medications. Once the physician practices start to say, I really want my patient to come in with their list, I want to reconcile that not just on paper to say I did it, but I want to have true med reconciliation, then the value of the pharmacy partnership really starts to come home, because it is a lot of extra work, and patients sometimes, in this environment, don't have all the data that we need to know what to do. So that med reconciliation is sort of an obvious place to start working together. The business model, sort of having people who want to kind of align and share patients in a more almost exclusive way, is another model. And then I think some of the performance measures that are out there. So there's paper performance targets that many practices have. Now they're beginning to report on HEDIS measures, and some of their HMO and commercial practices are reporting. They might be part of a physician hospital organization where they're getting some feedback on data. So chances are there's going to be a med management related goal on the to-do list for that practice that will get better. And that may be, so if it's the pharmacist coming at it on their side, I think them looking at what is it that I can do that's going to help that practice get one of their goals. If it's the practice side coming at it, it's going to be looking more at how's the business model work, how can I help make it better for our patients to have them use this pharmacy, so it's a win-win. And we're seeing that working. And the last element I would throw out there is the training model, the schools of pharmacy that really need and want to get their students and residents into clinical pharmacy encounters, having them actually practice and learn together. That's another element that sometimes works, is to be able to help broker a training site that comes together where faculty, students, and residents can begin to participate. And we know that when you have good training going on, it sort of affects the care in a more global way. Kyle?
Yep, thank you, Mark. Julie, really, I think your question that I would like to touch on is, you said, where would you recommend starting? And what I would do is I would have the doctor and maybe the nurses sit down and focus on 5 patients. Look at 5 patients they know of, maybe with diabetes, whose A1Cs are always elevated. And then with those 5 patients, call the pharmacy and say, when is the last time they picked up their metformin or their insulin or their ACE inhibitor? How likely are they to get it within the last year? How many times have they picked it up? And by doing that and forming that partnership, the nurse, the doctor, and the pharmacist can communicate when they see that patient. The patient could then come back in for a visit, and the provider can say, we know you haven't picked this up for 4 months. What is preventing you from doing it? And maybe there's education barriers. You know, I don't know, I needed to be on this the rest of my life, or I couldn't afford it, or maybe they had side effects. But identifying high-risk patients and then really using all the resources to get a better picture of why the patient's not at goal helps. One of the terms I really hate is they're non-compliant. They just don't do what I tell them to. Well, there's multiple reasons why. It's finding those reasons, eliminating those barriers to help the patient live a better life. And I think that's where you start.
Kyle, I love that. That is a great practical way of primary care practices to start to think, how might I use the pharmacy resources that I have available in my community. Perhaps you can talk about one of the things I find in working with primary care practice. I call it the Pandora's box theory. And if a practice starts to dig into perhaps the social determinants of a patient that might be impacting a patient's ability to be successful with their health goals, how have you seen that practices maybe work through that space where they might bump up against an issue that they don't have a solution for, and it might be around finances of a patient or a living situation? Are there any ways to sort of work through those types of barriers with the practices?
Well, I can start if you want, and then, you know, I think
Mark.
what we find that seems to be successful in this is to sort of talk about how we already do that. So there are good examples would be a physician seeing a patient who's got some low back strain. It's not, you know, surgical, and the Motrin's not cutting it, and we want him to get some physical therapy. So at that point, the physician's not going to take on the responsibility of prescribing and applying and providing and evaluating and following up on the physical therapy. They're going to make a thoughtful referral. And I think that's it. So that's something that most any physician sees. That is in my scope. That's a responsibility I have. I need to make sure I get the referral done, kind of coach the patient, you know, to get them to sort of help understand why it's going to help them and see if they'll make the effort to do it. And we're good at that, and we do that in all kinds of ways. Where we don't do that is when we don't perceive it as in our scope. And I think that's where exactly what you said happens. The patient can't afford the med. We say, well, you need it. Figure out a way. What the heck? You know, don't buy your cigarettes. Buy a med. We do some sort of, sort of relatively flip response, which just isn't effective. So I think the first step is to start to expand what the physicians and providers and the healthcare system sees as in our scope. So once we start to tackle this outcome-oriented goal, again, we talk about this in a sense of doing things right versus doing the right thing. So doing things right is exactly that. I say, yes, this is your problem. This is what's wrong. This is what's going to happen if you don't treat it. Here's how you treat it. Here's the prescription. I'll see you in a month. That's doing things right. I'm going to document that I warned the patient and I told them if they don't do this, they're going to die. Doing the right thing is to ask that next question. Are you able to get this medication done? The person says, well, actually, I'm kind of between houses right now, and I'm staying with a friend, and blah, blah, blah. Well, if at that point we say non-adherence and walk away, we're done. But so if we begin to say that is also now in the scope, I don't have to fix it, but I have to put it on the problem list, it begins to create the opportunity to say, where are those referrals? And most communities have some mechanism. It may be as simple as a church that has a walk-in ministry program, or a full-blown social service agency that has case management. The medical card, public aid, HFS, whatever the state system calls that, everybody has a case manager, and we know how to advocate. Physicians are very good about advocating, about writing a letter, kind of putting the ball in their court. So I think that's the key. Is step one is to say this is in my scope. Step two is to say I can't fix it by myself, which becomes the overwhelming part. What do we do in situations where we need help? We collaborate with colleagues and partners, and so building a registry of that begins to make a difference. So I think those are the steps, and again, I just come back to say we want to make this more of the same. It's not a new way to practice medicine. It's just doing what we do in a slightly larger framework, and I think the places that do that are seeing success. It might mean a new protocol or a new flow sheet or a new screening tool that you build in, so there's some systems things to begin to address it. And ultimately, at the end of the day, I think it does make the practice feel more rewarded because they can pay attention to some big impact things that really make a difference for the patient. And Kyle, I know you do that in your practice. You do this sort of thing out there at your health center all the time.
Yeah, and to really get, maybe a pretty simplistic response is that all the answers are in the room. If maybe one or two people know that the patient can't afford their medication, little is done. But by having group or team meetings, if you have a nurse, a pharmacist, a doctor, a social worker, maybe somebody from lab discussing patient can't afford this, what can we do? Somebody has the answer, and the answers are really in the room. The nice thing about the collaborative, we kind of have a virtual room where if we don't know the answers, we could just send something out on the listserv. And by emailing the question out on the listserv, we can really see how other teams are handling the issue and maybe what they're doing. I've posted questions before and gotten responses that I've never even thought of. And they're issues that we've applied to our practice and really made a big change. So I think, again, just getting together, coordinating care, and if possible, using a listserv. And that's really one of the benefits of joining the PSPC is there's so many people from 47 different states that are doing the work that have probably had the same problems you have in the past, but they've found a way to fix them, and they're willing to share.
Yeah, the answer. It's right, Kyle. The answers are out there, and I think again, it's just sort of putting it in the scope. This is on our to-do list now, and not by ourselves, but to be able to get it done. And I think the last point I would make is just things like the PHQ-9 depression screening tool. I mean, people are starting to use that more and more for non-adherent patients. Oftentimes there is an element of depression or anxiety or stress, and so just recognizing that and getting a referral may be the answer.
Well, thanks so much to both of you. We're at the top of the hour, and I'm realizing we probably could go on for another hour. And I think what you've given us, and which I find so valuable, is we know that integrated delivery systems prove value in terms of cost and quality. Geisinger Group Health, Veterans Affairs, the VA. And what you've shown us today is that even virtually integrated communities, organizations who have the same goal of delivering health and healthcare in their communities can work together with this type of a program to build and support patients within the community. So with that, I also want to thank Stephanie Hammonds with the Office of Pharmacy Affairs at HRSA for bringing these two wonderful speakers to us today. Thanks to both you, Mark and Kyle, for being willing to present to us. I have a feeling your phones will be ringing, your email inbox will be full, and people will be going to the website to learn more about this program. Thanks to everyone. We will now close this session and look forward to feedback from everyone, and can certainly bring our two speakers back for additional conversation if that is the will of the group. So thanks again, and wish everyone a wonderful Thursday.
Great. Thank you.
It's been a pleasure.